This is the sacroiliac joint fusion with Trident. Patient is prone. In the true lateral view, we mark the anterior and posterior border of the sacrum on the skin, and this gives us the orientation. And at this point, then we literally mark the border of the S1 disc and bone. From the promontorium, we go to the middle of the sciatic notch. The middle of the sciatic notch is the entry to the skin. This surgery is done perpendicular to the sacroiliac joint, so in the true lateral view, we are obliquely entering the skin at the middle of the sciatic notch. Skin incision is parallel to the sacrum, so we can mobilize it better. Entry to the bone is just anterior to the border of the sacrum, and that is because once we pass the iliac crest, we are centered on the sacroiliac joint perpendicular to it. It's preferable to work bottom up, because if you breach posteriorly, there are less vital tissue there. At this point, we go to inlet and so-called outlet view of the spine, which are true AP and axial view of the sacrum. Once our first dilator is on the bone, measurement is done for the size of the screw. At this point, obviously, the guide wire is at the end position. We use the bigger dilator, and then we create the pad. We don't use the drill anymore. We tap the small dilator to breach the cortical bone of the iliac crest. The connection of the inserter to the main screw is the most crucial part of the procedure. It allows us to create a pad from outside to inside, and literally the drill and tap with the screw through the iliac crest to the sacrum, and then we align the smaller windows, proximal and distal, in the so-called inlet view, which is the axial view of the sacrum. The main inserter comes out. There is a beveled broach or awl, and we are trying to breach the cortical bone in the direction of the screw. We want to be as close to the screw as possible, and by using this, as you see, the beveled part is toward the outside, so it brings the awl toward the screw. The angle should be around 15 degrees. Anything more than 20 degrees should be considered problematic. This is the side screw, and it has two steps. First, it goes inside of the screw, and then it sits in, so you don't lose it. And then obviously you go through the opposite side to go through the sleeve and put the proximal and distal screws that stabilize. The main stability is the main screw, and the side screws are for counter rotation. More importantly, at the end, you feel when you are done, then you make a quarter turn of a turn to lock this side screw into main screw. In the same fashion, you put the other screw. All screws have windows and grooves to be part of the fusion. And once the screws are done, you can fill the spot with biologic. This step is optional, since the screw itself internalizes significant amount of bone internally. And then once the positions are done, with the quarter turn, we remove the sleeve. I use neuro monitoring. It enables me to put the biggest possible screws, but it is optional.